Hello everyone. Today we'll be talking about VQ mismatch and why does it causes hypoxemia and how do you manage it. Before we understand this further, you have to understand that the total oxygen delivered to the body depends upon two key factors. First of them is your end capillary partial pressures, which typically equilibrate with the P alveolar O2, and this determines the oxygen content of the blood. The second most important factor is the amount of blood flow, and combination of these two will determine the total amount of oxygen leaving that alveoli. The alveoli with low VQ mismatch, they cause hypoxemia. For example, in this case, your P alveolar O2 is 100. This is a normal functioning alveoli. If you decrease the ventilation to this area, that means you lower the VQ, you can see that the oxygen supply to the alveoli is reduced, so the amount of oxygen that can go in falls down. And this effect is most significant at lower P alveolar O2. Once it falls less than 60, the total amount of oxygen carrying capacity by the hemoglobin molecules reduces dramatically. If you remember your oxy-hemoglobin dissociation curve, you are now on the steep portion of the dissociation curve. So anything less than P alveolar O2 of 60, blood flow to these alveoli would result in more hypoxemia. Alveoli with high VQ mismatch, they cause hypercapnia. If your perfusion to these areas drops, the amount of CO2 that can be blown out decreases. So in fact, all the ventilation that is going into this alveoli is a wasted ventilation. So let's talk about how much of low VQ mismatch occurs before you end up hypoxemic. So we'll calculate the total oxygen that is coming out of the alveoli, and that would depend upon the O2 content of the blood multiplied by the total amount of the blood flow through that alveoli. In a dead space, since blood flow is 0, the total amount of oxygen coming out would be 0. In this alveoli with high VQ ratio, your P alveolar O2 is around 130, so your O2 content is around 17.5. Thus, total amount of oxygen coming from this alveoli is around 175 ml, assuming 1 liter of blood flow through this alveoli. If we keep the amount of blood flow same, however, we keep on changing the VQ ratio, the total amount of oxygen that is coming out of this alveoli drops down to 170, which is not a very significant drop. And as your VQ ratio drops, you are coming down on this curve, and you can see that once you start hitting P alveolar O2 of around 70, the total amount of oxygen that is coming from these alveoli drops dramatically. Know that the venous oxygen content would be around 100 ml per minute in this case. So once you have got P alveoli reaching near 45, the total amount of oxygen that is coming out of these low VQ alveoli is pretty minimal. This graph shows partial pressure of oxygen and carbon dioxide in the alveoli with different VQ ratio while breathing room air. So with the alveoli with VQ of 1, you have PCO2 of 40 and PO2 of 100. However, if you have got a dead space, your PCO2 will be around 0 and PaO2 would be around PiO2. If your partial pressure of oxygen falls below 60, these are the alveoli that are causing hypoxemia. All the alveoli that are falling below this VQ ratio of 0.2, these guys are not providing enough oxygen in the blood that flows through them. So we have an area where the VQ ratio is pretty well matched, and that's where most of the oxygenation happens. So why VQ mismatch cause hypoxemia? Let's look at this two alveoli model. We have got a alveoli with high VQ and another alveoli with low VQ. The one with the high VQ has P alveolar of 130, so the oxygen sats that's coming out of these alveoli is 100%. However, the blood flow is much lower. The low VQ alveoli has got lower P alveolar of 70, and thus it has got sats of 94%. However, total amount of blood flow coming from this alveoli is much larger. The final partial pressure that is coming out to the left side of the heart will depend upon a combination of these two, and flow takes a very important part because more amount of blood is coming at 94% and a very small amount is coming at 100%. So the final O2 content will be determined by the flow weighted mean of oxygen content from various VQ areas. Let's do some mathematical modeling to understand this a little better. We have a high VQ area with a flow of 1 liter per minute of blood flow. So your P alveolar is 140, O2 sats are 100. We have a normal VQ area with P alveolar of 100 and around 2 liters of blood is flowing through these alveoli every minute, and your sats are around 97%. In the low VQ, we have got P alveolar of 45 and these alveoli are seeing a blood flow of 3 liters per minute. Thus, the end capillary sats are around 80% given your P alveolar of 45. If we calculate the total amount of oxygen that is coming from all the three areas, we should be able to figure out how much amount of oxygen is really reaching the left heart. So for the one from the high VQ area, you have got a sat of 100% and a flow of 1 liter per minute, and you can calculate it to be 13.8. Similarly, the oxygen delivery coming from the normal VQ areas is around 13.6 into 2 liters per minute, that is 27.2. And similarly, the one from the low VQ area, the total oxygen content is coming at 80% and 3 liters are flowing through. So 10.7 multiplied by 3, that's 32.1. Hence, total amount of oxygen that is coming out of all the three areas is around 73.1 or around 12.2 average. And you should be able to calculate a percent sats corresponding to this oxygen content that comes out to be 91%. Let's give this guy some oxygen and see how increasing FiO2 improves the oxygenation. Now we have got a P alveolar of 350 and you can see that percent sats are still the same. However, the amount of dissolved oxygen increases slightly, so we have slightly more oxygen delivery coming from this alveoli. From the normal alveoli, similarly, there's more amount of dissolved oxygen and that increases your oxygen content slightly from 27.2 to 28.6. However, if you look at those alveoli with low VQ, you are improving their P alveolar from 45 to 70 and around 3 liters are flowing through. So now your sats coming out of these alveoli is increased to 94% and all of a sudden your oxygen content increases, and compared to the previous one, the total amount of oxygen coming from these alveoli increases significantly. Similarly, you can see that once you average the things out, this will correspond to O2 sats of 100%. Even with low VQ, with a pretty high amount of cardiac flow through them, increasing the FiO2 improves the oxygen sats. So VQ mismatches respond to oxygen. The hypoxia in these patients occur because of very low VQ alveoli, since you are trending towards the shunt physiology. And similarly, your oxygen response will also depend upon how near the alveoli is to the shunt physiology. Let's understand in a more intuitive way. So we have seen this graph before. We have got VQ ratio and we have got the P alveolar O2. And while breathing room air, different VQ ratio will have different P alveolar in them. Alveoli with more dead space will have higher P alveolar O2 and the alveoli with shunt physiology will have much lower. And here we have normal alveoli with VQ of 1 with PO2 of 100. This area represents those alveoli with PA alveolar O2 of 60. So these are the poorly oxygenated alveoli. If you give them oxygen, you are going to increase the P alveolar O2 more in the areas which are better ventilated and lower in the lower ventilated area. The alveoli, which was sitting here at P alveolar of 60, now has got P alveolar of 100. So the oxygen carrying capacity through these alveoli has increased dramatically. So now you have alveoli with even lower VQ, which are now contributing more oxygen. As you increase the FiO2 further, you increase the total amount of alveoli which are now contributing to oxygenation. Thus, increasing FiO2 will increase your P alveolar O2, which in turn will increase the oxygenation coming from these alveoli. How does your VQ mismatch affects your PaCO2? This is mostly affected by the alveoli with high VQ ratios, and these would result in decrease and wasted ventilation. So in these cases, you will see increase in PaCO2. However, because of the chemoreceptor response secondary to hypercapnia and hypoxia, there will be increase in minute ventilation that would drop your PaCO2 to normal. Let's talk about VQ scatter. In a normal lung, you can look at all the alveoli and plot out a ventilation perfusion ratio on the x-axis and look at the ventilation or blood flow, and you will see that the most of the alveoli lie across the VQ ratio of 1. However, in many disease processes, you can see that the both ventilation and perfusion areas are different, and this leads to a term called VQ scatter. As the VQ scatter worsens, you will see that there will be areas tending towards shunt physiology, that is very low VQ areas, and areas with high VQ tending towards the dead space physiology. Areas with shunt-like component from low VQ areas will appear as shunt when you calculate the shunt fraction, and the areas with high VQ numbers will behave like a dead space. How to differentiate shunt from low VQ areas? VQ mismatch responds very well to oxygen. So one of the things that you can do is give the patient 100% FiO2, so you minimize the contribution of low VQ areas and just focus on the shunted areas. This should make your calculation a little bit more accurate. Whenever your lungs encounter a non-functioning alveoli, they cause hypoxic vasoconstriction in that area and redirect the blood flow to the normal alveoli. Two most potent stimulators for this are low alveolar PO2 and low pulmonary artery PO2. The low alveolar PO2 are much stronger stimulus for pulmonary vasoconstriction and increased pulmonary vascular resistance. So giving oxygen to these patients can reduce the pulmonary vasoconstriction and thus can be helpful in RV failure. AA gradient or AA difference is the difference between P alveolar O2 and P arterial O2. This can be useful in certain circumstances. P alveolar O2 is calculated from the alveolar gas equation, while P arterial O2 is measured from the arterial blood gas. The clinical utility of this is limited because it is increased in multiple conditions such as diffusion limitation, shunt and VQ mismatch. However, in a young healthy patient with no underlying pulmonary issues and a normal looking chest x-ray, an elevated AA gradient may suggest acute pulmonary embolism. Any disease that affects the airway, alveoli, interstitium or vascular can result in VQ mismatch. VQ mismatches respond very well to increasing FiO2, as we have seen. Patients with very low VQ would benefit from keeping these areas in zone 1 physiology, as we talked about in the shunt lecture. Proning can help these patients. You can use PEEP to aid in improving oxygenation. However, you have to be careful, as if you increase PEEP too much, it will increase the VQ ratio and move you towards the hyperinflation and dead space physiology. And if you use too little PEEP, it will reduce the VQ ratio and move you towards the atelectasis and shunt physiology. You can also use pulmonary vasodilators. VQ mismatch is the commonest cause of hypoxemia. Try to understand VQ mismatch along with shunt and dead space physiology in understanding and treating your patient. VQ mismatches responds very well to increasing FiO2, and you can use strategies such as PEEP, positioning and pulmonary vasodilators to improve VQ mismatch. So we are concluding our hypoxemic hypoxia series. Here we talked about all the 5 causes, and you realize that only one of them has minimal improvement with the use of FiO2, and that's the shunt. The rest of them respond very well to giving oxygen. These are the few references if you want to read further. Thank you.